Conference will now be recorded.
So here we go. The cell.
This conference will now be recorded.
Oh, thanks, CJ. All right. So the cell membrane protects and selectively allows water and other substances into the cell. There are certain disease processes, pathophysiologies, that cause this membrane to get leaky. When that membrane gets leaky, it's the permeability. So you'll see that word too. Don't ask me to spell it right now. Permeability. So the outside of the cell is what allows water and certain electrolytes to get back into the cell. Who remembers sodium and potassium?
That's a ribosome.
Huh?
Ribosome?
The sodium potassium pump sits on the outside and lets certain electrolytes into the cell. All right, mitochondria, the mighty mitochondria. Everybody knows that is the powerhouse of the cell. So that converts our glucose and other nutrients into ATP. That ATP is what gives us energy. That is energy. So that is fuel for our cell functions. Whenever we're talking about cellular metabolism, is what we're talking about. It's this mitochondria converting food into energy. So without that ATP or that energy, their specialized structures within the cell cannot function. What do you think that determines how much ATP is made?
The air one or the non-air one?
Yep, so aerobic or anaerobic. It all comes down to oxygen, right? So if somebody has low oxygen, called hypoperfusion, right? What is another name for hypoperfusion? It all comes back together. So if there's any kind of disease process or injury that is affecting the metabolism of the cells, it puts you into shock, right? There's another name for shock is hypoperfusion. It's affecting the body at a cellular level.
The only difference with the mitochondria work out does with or without the oxygen is just it's dirty or it's clean, right?
Kind of. So whenever it does have oxygen, it creates 32 ATP. There's a little lead coming up. But without oxygen, it only creates 2. So it only allows our cells to have so much energy without the oxygen. But yes, it is dirty in a way because instead of releasing ATP, it releases lactic acid.
And that's what causes the shock.
Yeah, so buildup of lactic acid causes like acidosis because it's acid, right? So our body at like a full, completely being acidotic, really bad, causes or is a byproduct of shock. That was What are you doing?
Nothing. I was trying to get this to pull up. Don't mind me.
Okay. All right. Any questions about this? Everybody got it written down. Here's just another picture of the cell. So I'm not going to be like that biology teacher that makes you label if that's just too much. Basically, what you need to know is the outside is what allows things to flow in and out of the cell. The cell needs oxygen, it needs glucose, and it needs water. And it needs a happy balance of all of that stuff. So you got to think about the cell, whatever enters your bloodstream has to get into your cell somehow. Whenever there's a problem with how much is inside the cell, it can cause types of shock, hypovolemia, sugar, we talk about all that stuff. So this should be in your book. If you want to print it out and label it all, cool. I'm not going to make y'all do that. All right, so cells, they need to have the correct balance of water inside and outside. So whenever there's too little water in the cell, that cell shrinks down and it dies, it dehydrates. So then too much water, the cells can get too big and some of them can even burst. But that function is interrupted. So whenever you guys start learning about like certain fluids that we're giving, we have hypertonic and we have hypotonic solution. So that affects how much of that fluid that we're giving actually gets gets inside of the cells, because that's ultimately where we want that fluid to end up, right? There can be problems when that fluid is out of that space, the interstitial space, and that's where we get like swelling, edema. Sometimes it can end up in your lungs. So it's important that this water gets into the correct spot. And then electrolytes. So what are some electrolytes?
Salt.
Yeah, sodium, salt, potassium, magnesium. There's one more that the thyroid uses a lot. Calcium. So all of our electrolytes are also, there's a constant influx and efflux of electrolytes into our cells. Our cellular metabolism is based on these electrolytes. So whenever we have an electrolyte problem, it can cause a slew of other problems. And that counts as like electrical abnormalities in your heart. I've seen somebody that looks like they're having a heart attack on a 12 lead, but it's just because their electrolytes were messed up. It can cause different kinds of seizures, muscle spasms. It can cause a lot of things, dizziness, changes in vision. So electrolytes are a huge thing. I like to say that the majority of our patients can be fixed with a good Gatorade and a good poop. And that's why, is because a lot of times our electrolytes are messed up anyway. All right, so glucose is what? Sugar. Good. So glucose is that building block for energy, right? You give a little kid sugar and they're like, oh, they're all energetic. So that's an easy way to remember that. But for that glucose to get into our cells where it's supposed to be, it needs insulin. What organ in our body creates insulin? Pancreas. Good. Good. So this is just a visual representation. This insulin is the key. We were talking about it a couple classes ago, but this is just so that insulin opens that door for that glucose to get into the cell. So whenever somebody's blood sugar is too high, we give insulin to bring it down, right? Whenever their blood sugar is too low, what do we give them?
Peanut butter and jelly sandwich.
Exactly. Yes. I have been a chef.
Orange juice.
I've been a chef in many of patients' houses, so whenever I'm making omelets or spaghetti or PBs and days, their sugar's low. So the important thing is there's different kinds of glucose, right? So there's complex sugars, and then there's simple sugars. When we're getting somebody's sugar up, say orange juice or our oral glucose that we carry, once we get their sugar to like a reasonable level, it is important to have them eat protein or carbs so they can keep that sugar up. So whenever you give them a simple sugar, their sugar goes up and then it comes right back down. Whereas if you give them a complex sugar, it goes up and it'll stay there and maintain until they eat again. Here's our aerobic metabolism. So these are our cellular functions. Aerobic, meaning it has air or oxygen. That's just how my brain remembers aerobic. So there's oxygen in this metabolism. This is prime time. Whenever we're metabolizing and we have oxygen, that is ideal for our body to be happy, right? So without oxygen, it's called anaerobic. It creates much less energy and much more waste, and that's the dirty that we were talking about, that lactic acid starts to build up. So a prime example of this in like real time is like whenever you go to the gym or you run or you work out, you are creating too much of a demand for oxygen in your muscles, right? So whenever you have that, makes your muscles start to use an aerobic or an anaerobic metabolism, that lactic acid builds up. What happens to your muscles? Yeah, you get cramps, they get sore because that lactic acid builds up, and it takes a couple days for our body to metabolize that extra lactic acid out of there.
So don't work
So don't work out.
out. You know what never caused my muscles to get sore? Donuts.
Maybe this one. So the
Those are
thing.
bad donuts.
Mhm.
I said, those are bad donuts.
That's true. So the big thing about patients that have gone into shock is they become acidotic. So this might be a test question eventually. I don't know if it's going to be on our next test or not, but I just want to bring it up while we're here. What's the normal pH of our body?
It's like slightly acidic, right?
What's the numbers?
It's 14 is basic, and then 7 is normal, and then 0 is acidic, right?
So if it's this way, is this acidotic or alkalotic?
It's
Just simple,
acidic,
you said.
alkaline, increased salt, meaning it's more basic, right?
This would be more towards the base, yeah. But our body is happy right here. 7.35 to 7.45. So once we get them to the ER and they pull those blood levels, they can check the blood gases, is what they're called. This is what they're looking for. And so usually our septic patients, our patients that are in shock, they're going to be more towards like the 6 numbers. They're going to be lower 7 than 7.35. So this might be a test question. Usually they like to ask, what's the pH of a human body? There's your answer. I don't think we have one coming up. It might be, just know it. That's a good number to know. And then the 3.5 and 4.5 helps you. Because our next chapters that we go over are carbon dioxide levels. Normal for a human is 35 and 45. So 7.35, 7.45, 35, 45, those are just good numbers to know. It's good to see them now, so whenever you see them later, they kind of stick a little bit better. Here's my bean that I was talking about. So depending on which textbook you read of how much ATP is actually produced. Some textbooks say 32, some say 34, some say 36. But we use 32 of it. And this all happens at the Krebs cycle. I'm not going to kill your brains with the Krebs cycle. That comes in paramedic school. So whenever you guys get there.
Can
Yes.
you suffer from shock in an
Will you
alkaline
turn that?
state?
Yes, you can.
Will you turn that camera so that Austin can see it?
Oh, yeah, yeah. Do I just hold it here for a second?
Yeah.
Yes, you can have an alkalotic state. So usually it's not like someone just sitting there, they got sick and then they're alkalotic. Usually that's caused from like an outside factor, like somebody took too many Tums is a big one.
You can take.
Yes.
Oh, yeah. You can feel crap out of yourself, don't
Yes, you can.
That's for you.
100%.
Oh, man. So
A lot.
Listen.
all the time.
you know how many 14-year-olds try to alter themselves with Tylenol? They'd be better off trying the Tums.
Holy crap.
Like, I'm not even kidding. Like, the amount of Tylenol you have to take to, like, truly commit suicide is a lot.
Is a ton. And it doesn't even kill you fast. It's like one of those things that like you're like, I want to kill myself. You take all of it and then years later your liver's like, see ya, and then you die.
Yeah, and then you go through freaking. Yeah,
It is,
it's not
yeah.
fun. But like Tums,
So how much is too much Tums?
well,
I don't know an exact number.
no, but it can kill crap out of you. You can take your body and put your body up closer to that like 8. I have personally never seen somebody do that. I've seen a lot of 6s in the pH realm of things, and they have been like.
Hey, Jesus.
They're looking at Jesus' skirt like, what's up?
So like the same boat as Pepto and stuff, is there a safer?
I mean, as long as you take those in a reasonable manner, it's not bad. But like, if you took like a bottle of Tums and just freaking downed it, probably gonna be in bad shape.
And you probably wouldn't shit for like at least 2 weeks.
Just chalk.
Or poop, I'm sorry. Yeah. Yeah. So here's just a visual representation of that aerobic metabolism. So you can see right here where it says oxygen and glucose. Oxygen is the key here, right? So it has oxygen. So it goes through its little Krebs cycle. and then it spits out 32 ATP. And then our body uses that ATP for energy. This is metabolism.
You make your metabolism faster.
Can you make it? Not more glucose, I know that. I'm sure you could, because if you're like metabolizing quicker.
Yeah, like if you exercise and stuff, they say it'll raise your metabolism some, but I think that's just more burning calories and stuff than it is.
And I don't think it's like I exercise once and then I'm good.
Pretty faster.
I think it's just your body's way of compensating for the overburn of calories.
People say, oh, I have a fast metabolism. Or like, I don't, but like people say that.
Yeah, I'd like to have one of those. I look at a donut and it gains 6 pounds.
I can do whatever I want. Like, I'm always hungry.
Yeah,
Yeah, that's why Marcus is, bro. That little bastard right there can freaking eat.
yeah.
Yeah, do that.
Freaking pisses me off.
Like,
I do with the
Yeah,
freaking
so-
Taco Bell and spent as much money as me and Becca did together. I was like, where the freak you put all this stuff? He's like, well, you did. Okay. You think?
It's probably like the only time he eats a day, too.
No, that dude eats like 7 times a day. Trust me, I work with him. And don't forget to feed him. It's worse than being married. No, their monthly cycle. If you don't feed him, he gets very angry.
So here's the anaerobic, so without oxygen. So you can see that the oxygen here is crossed out. So then this ATP goes from how many?
32.
32 to 2. And then it also has this byproduct that is just so lovely. It hurts, right? So whenever you work out, your muscles are sore, you can blame this guy right there.
What's pyruvic
Yes.
acid?
Huh?
What's pyruvic acid?
It's just,
The first step?
First step.
Lactic acid?
yeah, don't ask me to recall the process from here to here because there's something else. And I had to learn that once and then it was like, see ya. Calvin should be here. He could answer it for you, I'm sure. He's very smart. All right, so many diseases can alter the permeability of the membrane. Whenever we start talking about like congestive heart failure, that can affect our cells. You can get like a buildup of fluid. Sepsis is a big one. So if somebody has any kind of infection like pneumonia, a UTI, a bad tooth, any kind of infection can cause sepsis. So that can alter that membrane. And then that membrane can allow substances into the cell that shouldn't be there. So an excess of electrolytes, extra fluids, extra glucose, all that stuff can be affected because that cell lining becomes more permeable. So it lets more things out, but it also lets more things in that shouldn't be there. And then the regulation of water is affected because all of that is affected by the lining of our cells. And so whenever that is in the pooper, then this also goes in the pooper.
Can you go back a second?
Yep.
Thank you.
Sorry, this one or this one?
Nope, that one. Thank you.
Okay, no problem. I get excited with the click.
So if you loaded your body with oxygen, like those deep sea divers do, before you work out, you wouldn't be sore?
Probably be less sore, I'm assuming. There's some like, especially if you're doing like you hear about people going up into like higher elevations where there's less oxygen and it causes like a shift in your cells. You can get like mountain sick. So a lot of like people that are running marathons that are going to a higher elevation, they'll train or they'll wear oxygen.
I think there's a nice thing by bodybuilders.
Yeah, your bodies are just like,
No, it's just like
Sometimes chemicals on your face that change your body to.
I mean, if you train it, it's got to build up to get there. And then like us, we're acclimatized to this elevation here. But like you go to Georgia or grab someone out of Georgia and put them in the middle of Nevada mountains and tell them to go hike Lamoille, they're gonna be huffing and puffing. We were there. We came to visit the family like 2 Christmases ago, and they're like, "Let's go hiking," and we were like, "Yeah, we go hiking all the time." And we get up there, we're like, "No, when we first moved here, we went and hiked like up by Mount Wheeler, and we could not eat and walk at the same time because we were like, so.
On the
Your
flip
body
side,
has got to
to
be-
Alaska and did a hike and we were cooking. Move, we're like, dang, there's so much oxygen.
This is great. Calvin, I have a very, very smart question for you. How does pyruvic acid turn into lactic acid?
Why you asking?
You don't have to answer, I'm just giving you crap. All right, so homeostasis, whenever
Krebs cycle.
Krebs cycle, but I don't remember like the actual like process.
He did.
Okay.
Long and drawn out point.
Okay.
And there's 33.
No, you everywhere you read it.
Wait,
it
it makes 33 ATP,
Yeah,
32,
36,
33.
33 is bioavailable.
but that's the pyruvic, what is it?
So listen, like I said, the ATP, depending on what textbook you read, ours says 32. Others are gonna say 33.
Right, but that picture was an anaerobic, so it said
Right.
there was only 2, but
He's
it's still
talking about this. Whenever it does have oxygen.
with the pyruvic acid.
No, that's a whole
He
nother
was
thing.
just talking about the Krebs.
Oh,
Yeah,
okay.
yeah, that's a whole nother thing.
Rabbit hole.
Krebs cycle, just no Krebs cycle.
Diet
Metabol-
leads and get really lost really fast.
Yeah,
Yeah, we ain't gonna do that.
yeah, not that. Took me weeks to learn the Krebs cycle for the one test, and then I forgot it. Okay, so basically, when everything is happy, all the cells are happy, it has the appropriate amount of oxygen and glucose and water, it is called homeostasis. So our body is always fighting to get to homeostasis. So whenever our pH is too low and you have a really sick patient that is really acidotic, you're going to see signs and symptoms on them. That is their body trying to get back to homeostasis. So we'll talk about that more in detail later, but just know that our bodies aren't here to like kill us. They're going to try and save us, right? So whenever we're not in homeostasis, our bodies try to make up for it one way or another. So homeostasis is regulated in the brain. So the key structures are the hypothalamus, which is right here in the brain, and then our medulla oblongata. My mom says that alligators are so angry because they got so many teeth. So our brain, where does this sit? Point to it on yourself. Right here.
That part back here.
Right, so it's right here. Our little brain stem fills right here. Whenever we have brain injuries, remember there's that big hole in our skull. And when our brain is starting to swell and it has nowhere else to go except for this hole, what's the name of that hole? I forgot. But I think the line site you have a foramen, right? So foramen magnum, which means big hole, pretty sure. It starts to push your brain out of there because that's the only place that it has to go. It's called herniation. Well, our brainstem sits right there. So whenever our brainstem is being pushed on, because our brain is swelling, that's affected, right? So it's going to deal with our breathing, it's going to deal with our blood pressure, all that kind of stuff.
Oh, it's so much.
That was aggressive. Everybody got this right now. Good. All right. So our fight or flight response, this is that parasympathetic and sympathetic that we were talking about, you've seen. So parasympathetic is your rest and digest. And then your sympathetic is your fight or flight. So if I run up to Chad and say, scare him, it triggers his sympathetic, right? His heart rate's gonna do what? It's gonna speed up. He's a puncher. Listen, you can't scare Chaz because this is his first reaction. And I've learned that the hard way. Don't do that. So your heart rate goes up, what else happens? What happens to your breathing? It increases. Good. What happens to our pupils? They do dilate. So I always just remember it. They dilate because your eyes are trying to take more information in. So sympathetic, you're chilling. This is your rest and digest. So if you spend your life stressed out or like anxious all the time, usually you have digestive issues, right? Because you can't rest and digest whenever you're constantly in a sympathetic response. So I'm going to tell you how I learned this in EMT school, and if it works in your brain, that's great. So I remember, or I was taught sympathetic because you can't run from a bear with a heart on. So this is your feed or breathe is your parasympathetic. So that's how I remember. That sticks in your brain. That's great. Huh?
Can't run from a bear with a heart on.
Yeah, because it's like extra on here on the word, but then also it is your feed or breathe.
Get it.
So you can't run from a bear if you have a heart on. Yeah, so everything's resting. Woosah. So our neurotransmitters that talk, our brain talks to the rest of our body like, hey, we're chilling, we're resting and digesting. So this reduces our heart rate and our blood pressure. So do know that there are certain medications that can cause like too much stimulus on your parasympathetic nervous system. And so that can make your heart rate and your blood pressure go too low. A big one is like organophosphate, like what they spray on fields, like the chemical, can cause like too much parasympathetic response. Then you have your sympathetic, so this is your fight or flight. So epi and norepi our body makes, right? So adrenaline. And then it enhances our body's ability to protect itself. For Chaz, it's punching. For me, it's probably going to be running away. Not a fighter. So then the heart rate and the blood pressure are going to go up in a normal human, right? So we always have those few outliers. Completely chill. Their adrenal glands are shot and they don't have any epi or norepi in their system. So we do have a medication that mimics this nervous system. Does anybody want to guess what it is? Yeah, that mimics it. There's another one. Albuterol. So whenever we do an inhaler, which you guys can give, albuterol is a sympathomimetic. So sympatho, and then mimetic, it's mimicking. So, but yes, the EpiPen, we create our own epi and we carry epi. And so whenever you give epi, what do you think is going to happen to their heart rate? Yeah.
So an inhaler will increase your heart rate too?
It can, yes. Yep. It mimics your sympathetic, so it's going to increase your heart rate. It's going to open up your bronchioles in your lungs, help them breathe. But if anyone in here has ever used albuterol, use it too much, or if you have never used it, you get shaky. That's why your mouth gets all dried out. Yeah, EpiPen can do the same thing. Yeah. Same kind of like thought. If you use like a lot of stimulants, like caffeine, nicotine, your mouth gets dry. We can think our sympathetic nervous system. All right, any questions about sympathetic and parasympathetic? So what does our heart rate do when our parasympathetic is decreased? All right, cardiopulmonary. One little guess. All right, so respiratory and our cardiovascular systems, they work together, right? We learned this in our last class. So they bring oxygen to everywhere in the body. So our blood goes through our heart into our lungs via what vasculature?
Pulmonary.
The heart. The what?
Pulmonary artery.
The pulmonary artery, right? And the artery, the pulmonary artery is special because it's the only artery that carries what kind of blood?
The oxygenated blood.
Good, good, good. Look at y'all. Look at you. So proud. I didn't even hear what he said.
Well, it didn't work on the test.
Maybe we should have
No,
did this
no
and then the test. So these two, they work together. They oxygenate our blood, and that oxygen gets distributed to the rest of our cells. The rest of our cells is perfused, right? So then it comes back to the end of our cells. It goes through metabolism, and that waste product gets put back on our blood, and we breathe it out. Or we poop it out, or we pee it out, depending on where it's gonna go. But we breathe most of our stuff out. So, fun fact, if you hold in a fart, you can breathe it out later. So, that's a fun
The guys in the room don't have to worry about that, that's just for the girls.
fact. So, any breakdown, so anything affecting the heart or the lungs or the vasculature, so our vessels, our arteries, our veins, can cause system failure because they all work together. It's all one happy family. And then whenever one thing gets kicked out, everything else is going to start failing. Does that make sense? Here is our bronchial tree. So our bronchus, it starts up here. This is also called what? What lives right here?
Thyroid.
Okay, but what's inside there? Our voice box, our
Larynx.
vocal cords. Yep. That's called our voice box. I'm gonna sit down for a break. So our voice box lives in the larynx, so our little vocal cords hanging out in there. Then our trachea is what you can feel that has all the little rings on it, right? And then that keeps this little area right here where it bifurcates, it splits into two, is called your carina. And then it just keeps branching out, branching out, branching out. It turns into a little tiny tree. So if anyone ever tells you I'm going to bifurcate your carina, my EMT instructor used to tell us that all the time when we wouldn't shut up. It's already bifurcated, so. So at the end of our bronchioles live the ravioles. They're actually called alveoli, but I just call them ravioles. So there are these little sacs. They're microscopic. They're so tiny. They live at the end of all of our bronchioles. And this is where that gas exchange happens. When I say gas exchange, I mean our oxygen and our carbon dioxide. That's where that exchange between the two happens. And it happens because our body pushes our deoxygenated blood up here. It runs along our ravioles and gets reoxygenated. And then all of the byproducts of metabolism, the stuff that it wants to throw away, gets put back into the lungs for you to breathe out. So these capillaries, teeny tiny, they're the smallest of the vessels, right? They're so little. So what kind of things do you think can build up in the alveoli that can cause a problem with oxygenation or offloading of gas? Mucus. Yeah, good. What else? Huh? Yeah, fluid. So like if you think pulmonary edema, so edema meaning buildup of fluid, pulmonary being in the lungs. So if you have like some kind of heart failure, it can cause these little sacs to fill up with like fluid, and so that oxygen can't get exchanged. Another thing is if you have somebody with really, really sick lungs, they can have something called atelectasis, which is where these alveoli just collapse. So then they're just not available anymore. So they'll collapse, and then they're just like, I'm done doing my job. See you later. So then your oxygen is affected. All right, so whenever we start going into our assessments, right? So that sheet that I gave y'all, hopefully you looked at it again since I handed it out, just to get familiar. You're going to see this a lot. Is the airway patent? So whenever we're talking about a patent airway, that means that it's open, it's not obstructed. So me talking to you right now, I have a patent airway. You can tell because I'm talking to you in full sentences, right? So we have different kinds of pathophysiology that can affect our airway being patent, whether it's from an outside source, like I freaking ate grapes too fast and it got lodged in my airway, or some other things that can cause it are like infection or trauma. So this is the first thing for the majority of your calls that you're going to check to make sure is okay is the airway. If you do not have an airway, you do not have a patient. The only thing that really deviates from that is if they're bleeding out. Obviously, you're going to want to stop the bleed before you start worrying about their airway. They can breathe all day long, but if they don't have any blood in them to oxygenate, that's a problem, right? So upper airway, at what point in our anatomy is it called that upper airway? From this point up, what structure? Top of your trachea, your larynx. So that's where it's defined as the upper airway. So larynx down, larynx, however you want to say it, down, lower airway, and then upper airway is from that point up. So a big thing that you're going to see, and we'll learn about, is any kind of upper airway thing. They like to tell you about this noise that people make. It's called stridor. So whenever you hear stridor, that's always going to be an upper airway obstruction. And it sounds like this. That's the best I can do. So, thanks. Thanks. I practiced before class.
You did. You was standing in front of me.
Yeah. So then the lungs, remember they're part of the lower airway, they're down here. So whenever we talk about tidal volume, this is how much air is moved in and out during each breath cycle. So the volume of air in milliliters that I'm breathing in at one time. Does anybody know the normal tidal volume-ish? Not quite. For an adult. Maybe for a kid it'd be 150. So it differs from male to female, right? Females are usually smaller in stature. Usually it's about 500-ish. That's the textbook answer. Just know that this is based on their ideal body weight. So how tall are they, blah, blah, blah. It does not have to do with how fat somebody is. And I have a picture up here that's going to prove why.
So on the tidal volume thing, when we were talking about bagging patients, that's where that goes into play. Because if you remember when we were saying those bags carry like 1,500 to 2,000 mLs, right? If your normal tidal volume is around 500, give or take a few, right? Like you're giving them almost 1,000, almost triple what they need if you deflate that entire bag. So you can see how that can become problematic. If I take a balloon, it's only going to expand so much before it pops, right?
So I made this last year when we had the Promethean board up. If you want to take a picture to kind of help, like put it into like a visual perspective of what each of these numbers are talking about. So tidal volume is how much is taken in. This represents one breath. Each blue box is one breath. So about 500, depending on the person. 500 is your textbook answer of normal. So each breath, 500. That's your tidal volume. Obviously, you're counting the respiratory rate whenever we start, counting and doing vitals. But all of this together, so your respiratory rate times your tidal volume. So let's say that they're breathing 20 times a minute at a tidal volume of 500. That number is your minute volume. So these are important to know because I'm pretty sure there's a question on one of your tests that it tells you the tidal volume is this and the respiratory rate is this. What's your minute volume? And you just time them together. That's how you get your minute volume. So how much they're breathing in per minute is going to be tidal volume times your respiratory rate. Got it? Everybody got a picture of this? This is how my brain works. I have to see things like this. So.
We're taking
So-
the test, but you can use our phone for a calculator.
I don't care. We'll know which question
You can
it is.
use your phone here as a calculator, but whenever you go to take your national registry, you won't be able to. I think they have a calculator built onto their computer, don't they, for questions that take calculations.
Yeah, they do.
I'm good with numbers, so.
Yeah, not everybody's good with numbers.
That's the only thing I'm good at.
tidal volume going to be assumed to be 500 or?
In an adult, yes.
So it's assumed, okay.
Yeah.
I wasn't sure if there was a way that we were gonna be measuring it.
There is a way. But you don't learn that until paramedic school. So it's,
What are you talking
The assumption
4
of
to 6.
tidal volume being 500.
about? 4 to 6 milliliters per kilogram.
Oh, it said that in the book. Or like 1.
And this is based on ideal body weight. So 4 to 6 is gonna be your magic number. If you have a test question that's like, how do you calculate what's an okay tidal volume? 4 to 6 is your magic number. They're never gonna, in EMT, actually I say this, I'm not gonna say never. The chances of them giving you a question that's like, you have a female that is 5'3", what's their tidal volume?
Because this only matters to us when we put patients on like vents and we intubate them and we put them on vents because we're trying to get like a target number for the vent itself to actually breathe for them. So we have to be more precise with what we're doing. For y'all and the bagging, there's no real solid way with that bag to say, well, I'm giving them 526 mLs every breath. Like,
We actually have a device that does that,
Yeah.
but just assume you're not more than that.
and that device actually auto defaults out to 500 mLs. So it just lets you, it has a little expander on the screen and expands out until you hit 500 mLs and then it gives you a little green light and stuff. So,
Any questions about this? No, okay, a lot of numbers being thrown at you today, and I apologize. So this is why size doesn't matter when it comes to like how chunky your patient is. Because my brain, when I was first starting EMS, I'm like, oh, that person's huge, they need the biggest airway I got. Don't do that. This is why, look at the size of the lungs. Do they change? The size of the lungs does not change. So whenever we're dealing with anything airway, and that goes all the way up through paramedicine, if you decide to take that route, from this point on, we go off of ideal body weight. And this is based on the height of your patient. If you're ever like questioning, like someone asks you, what's their ideal body weight? Google it. Because I have a chart that I keep on my phone for like when I'm actually running calls. I'm like, oh, ideal body weight. It's just, I have a whole chart that tells me what it is. Because I'm not going to sit there and do the math. Number one, I suck at math. Number two, that's too much to think about when I got other things going on. So make things easy on yourself. So just remember, their airway does not change because of their size. This is important for you now whenever we're talking about bagging your patient. Don't be like, oh, they're big, they get this whole bag. Don't do that. So, any decrease, this is like obviously, but they want me to make a point about it. So any decrease in tidal volume or respiratory rate reduces minute volume, right? You times a lower respiratory rate by a lower tidal volume, that number is going to be lower when you get to the minute volume, right? So respiratory dysfunction occurs anytime something interferes with the minute volume. So how much you're able to take in or how quickly you're able to breathe. So if you think about it, we have different kind of breathing patterns that you're going to learn about. But if I'm breathing 32 times a minute, do you think I'm getting a tidal volume of 500? Do you think that's physically possible? Not for long. Not for a long time, exactly. It's not sustainable. So what's something that could interfere with minute volume?
An asthma attack?
Asthma attack, good. What else?
Somebody hyperventilating.
Just hyperventilating, yeah, anxiety, right? Good, good. What about like a chemical exposure? If I am exposed to chlorine gas and it burns the inside of my airway, I think that's gonna affect me.
choke.
Choking, 100%, choking. All right. So respiratory dysfunction, double chains around his lungs, he can't breathe. Just can't breathe. So respiratory control is by the medulla oblongata, again, medulla oblongata, which is right here at our brainstem. So any event impacting the function of the medulla oblongata can affect the minute volume. So infection, drugs, toxins, trauma, intracranial pressure can cause it, right? Everybody get that. Sorry. I'm working on clicking slower. While you're writing, I'm also. We talked about this last class. So I'm gonna write it like this, just to make it. These are my arrows. See if I can, I don't know. I will have to show them when we get there. I don't think that camera's gonna reach over. What I heard on board. Okay. So, when we start talking about, like physical things that can affect the lungs, like trauma. So obviously a hole in the chest wall is gonna affect your breathing. Why? So we say pressures needed for breathing are disrupted. What kind of pressure system do our lungs work off of?
Negative.
Negative pressure, right? So if you put a puncture in that negative pressure system, you got an air leak, right? So obviously that's gonna affect our ventilation, our breathing. And then air or blood accumulating. So whether there's a hole in the chest or not, if someone gets punched in the chest hard enough, or sometimes like cancer patients, their lungs can just collapse. Tall, skinny, white men, that's the demographic of somebody's lung to just collapse. That's going to be it. That's probably a test question. We'll talk about that more later. But if you ever get a national registry question where it's like, your patient is 6'3" and he's a white male and skinny, and now he's complaining of shortness of breath, it's always going to be a spontaneous pneumothorax. That's the rule.
Looks like
Marcus is a prime example of a spontaneous pneumothorax. This guy is too.
I've been waiting. I'm gonna get that other one day. One day.
Cal is like, no. So any kind of air or blood accumulating in the chest. So pneumothorax, meaning pneumo meaning air, thorax meaning thorax, right? And then you have a hemothorax. So hemo meaning what? Blood. So blood accumulating in the chest. It can also compromise respiration, right? Because it's going to push on your lungs. And then your lungs can't expand like they're supposed to. So here's a visual example of that. So you have your pneumothorax. Sometimes there's a hole, sometimes they're not. So these can be caused by like a puncture wound or something. Sometimes it can just be caused by blunt trauma. Someone gets hit in the chest hard enough, they get in a car accident, their chest hits the steering wheel, it can cause a pneumothorax as well. So what happens is this air pushes in and it starts to fill this area with air, and this lung starts to collapse, right? But what lives right here in your mediastinum? Your heart, right? So it's literally squishing your heart, like. So not only is the heart not pumping efficiently, the lungs not expanding efficiently. So cardiopulmonary compromise, right? Same thing with blood. You can have a patient where it's just completely full of blood, or you can have a patient that has both. So this is called a hemopneumothorax. That's a mouthful. They just got everything in there. All right, so trauma or medical problems can affect the alveoli, right? So medical problems, meaning like asthma, COPD, that can cause it, or trauma. If somebody like inhales something that they're not supposed to inhale, that can cause problems. That includes like smoking, puffing, the lipids thing that can affect you. So whenever this gas exchange happens at our alveoli, less oxygen has a more difficult time getting to those capillaries. And then that carbon dioxide also has a problem getting out. So whenever we have a buildup of carbon dioxide, that is called hyper, meaning high, hypercapnia. So just know that when someone's not breathing at all, like your overdose patients, not only is the hypoxia gonna make them crazy, but hypercapnia can also make somebody. So there's your big words. So hypo means what? Low, and then hyper means high. And oxia. Good. How do we check oxygen levels? Yeah.
You're talking.
I'm pretty sure, like in the vital signs chapter, they say SpO2 is not a vital sign. Pretty sure. I feel like if anything's not going to be a vital sign, I don't even know. I thought that was silly. I just put it in there, but I'm going to talk about how silly this is. There's my crazy guy. I always think of that scene from Ace Ventura too. He's like talking about the bat, and he's like, that's what I think of. All right, so our body, like I said, it's going to try and save us, right? So it's going to try and compensate one way or another. We talked about those little receptors that hang out that test our blood and like report back like, okay, you need to breathe more or you need to breathe less. Those are called chemoreceptors. So they're receptors that are measuring chemicals, right? So then our brain reads those chemicals, the chemoreceptors talk, and the brain stimulates the respiratory system to either increase or decrease. And so you're going to see certain breathing patterns that are very specific to certain pathologies. A perfect example of that is like hyperglycemia. Like if someone has really high blood sugars, they get something called Kussmaul respirations, where they're breathing super fast and super deep because they're so acidotic that their body's like, we need to get rid of this acid. So it tries to fix itself by breathing super fast. And so here's where the chemoreceptors live. This is really small, I apologize. But the medulla oblongata, the carotid bodies, and then in the aortic bodies. So they're everywhere, and they're always testing, sampling, and letting your brain know, like, okay, this is what's going on. And then our brain's like, okay, we'll fix it by doing this. So that it's always talking to each other, right? Everybody get that written down. Okay. All right, so we talked about the components of blood last class, but we're going to go over it again. So, oh, I put there's a little thing. Which one of these things is the biggest component of our blood? Plasma. Good. Then we have our red blood cells, right? So our red blood cells, they have hemoglobin, which carries our oxygen, right? So if somebody has anemia, what does that mean? Less red blood cells, no red blood cells.
Or can it be that the red blood cells just don't carry oxygen well enough?
There are 4 different types of hypoxia. So yes, that can be one of the factors. So you can have a disruption in how much oxygen is actually getting in the body. You can have a disruption of how well your red blood cells are carrying oxygen. You can have a disruption of like the actual flow, like the road your red blood cells take. And then you can have where like your tissues just can't pick it up. That makes sense. So it's like a school bus. The red blood cells in your school bus and all the oxygen molecules get on and they get to the capillaries and they're like, see ya. And sometimes they just don't want to get off. So our white blood cells are also called what? Leukocytes. Good. And those help fight infection. And then our platelets start to form clots. Whenever you get cut or something's going on in there, your platelets are like, all right, let's form together and they all start making a clot, right? So our pressures in our blood. So pressure's big thing, not only for breathing, but also for our blood. So our plasma oncotic pressure, the proteins in our plasma attract water away or from or around cells to put into the bloodstream. So like we were talking about in one of the earlier slides, like we want homeostasis. We want all this to be perfectly balanced, but there's systems in place to keep everything balanced as it should be. And this is one of them. So if you guys have ever heard of like, what's the word I'm looking for? Osmosis. There we go. Osmosis is a perfect example of that. So you have solutes inside and outside of the cell, and it's going to try and match. It's going to try and be homeostatic. So it's the same on the inside as the outside.
Have you seen Osmosis Jones?
Of course, I've seen those. I love that movie so much. All right, so blood dysfunction. Yes.
Go back.
Yes. Sorry. No, you're good. No need to be sorry. I told you I get excited when I click. There's a lot of information on all of these slides. So pardon me. I'll let you. Bye. Smell you later. Let me get the chapstick off there first.
Yeah, it's like,
Okay. I always have fun. Good. You don't need to be sorry. I'm sorry, I clicked so fast. All right, so then we have problems with our blood, right? So blood dysfunction. So not enough blood, oxygen can't be moved because oxygen hangs out on our hemoglobin, right? That's on our red blood cells. So if we have a problem with blood, so not only if we have a problem with our lungs, but if we have a problem with our blood, remember that our blood and our lungs and our heart all work together in our vasculature. So any disruption of one of those things is going to affect everything, right? So let's say that it's our blood that's being affected now. So without proper blood, oxygen and carbon dioxide cannot be properly moved around. So whenever that can't be moved around, doesn't matter how much or how fast you're breathing, you're not going to get the oxygen that your body needs, right? So some things that can affect this, obviously, bleeding all your blood out is a big one. You don't want to do that. That's why it's important whenever we start going through these skill sheets, is that if you see bleeding, worry about that before anything else, right? So you want to stop the bleed. That is so important. Dehydration is another thing. Anemia, we just talked about, meaning lack of red blood cells, right? And then liver failure. So our liver, if you have problems with your liver, you can also have a lot of like clotting problems, because all of our clotting cascade, the way our body's like, hey, we need to clot, we have a cut here. All of that is from our liver. All of those little enzymes and proteins come out of our liver, most of them. What about, like, you guys out at the mine, probably get lectured on this a lot. What about like cyanide poisoning? I was like, cyanosis, cyanide poisoning. How do you think that affects our liver?
It just drops you dead.
It does drop you dead. That's absolutely what it does. And I will say that those cyanokits, if somebody finds you and you're already down, the chances of that thing fixing you, pretty slim. Pretty slim.
I heard a story of somebody using one of those on deer.
So there's a lot of, I've seen some things. Apparently the, what's the one, not the cyanocobalamin, what's the other one?
Caustic.
No, it starts with the A. It's a cyanokit,
Oh.
but
amyl
it's
nitrate.
the name, yes, amyl nitrate. So I did a report on that in primary school, and I learned that it relaxes your butthole. So people like to use it for their own pleasure. So that's a fun fact.
Whoa.
I am full of fun facts today. But cyanide it makes your cells physically not able to use oxygen. So that's the problem there. It's called a histotoxic hypoxia.
Andy said he just wanted to be around the drill.
Yeah, I learned that. I was doing a report on it, and they're like, a lot of times they lock up the amyl nitrate because of that reason. People like to steal it and use it for something. Yeah, I don't know. Like, I would be worried about shitting myself. But whatever. All right, so here's our blood vessels, microscopic, right? So it all comes down. This little guy right here is called a sphincter. Everybody thinks butthole. Buttholes are just gonna be the topic today. Everybody thinks butthole when they hear sphincter, but just know that there's sphincters everywhere. You got little tiny sphincters in all of your veins, and that's what keeps the blood flowing the way that it needs to go, right? Our veins constrict and dilate, and then these things help move it along. So that's fun. You got little valves in there. Then the capillaries is where the gas exchange happens, so our cells can get oxygen. But yeah, little sphincters. So that's just a fun word. That picture should be in your book too. Yes. All right, so our blood vessels. Whenever you hear the word vessels, when you hear the word vasculature, venules, veins, all of this is talking about vessels. So what is carrying our blood? So they take oxygenated blood from the lungs via heart to the capillaries. So it's a big old system, right? So the heart goes in, it oxygenates our blood, pumps back out to our body, gets deoxygenated, comes right back. All of that is done via our blood vessels. This is the highway for our blood to travel, right? So gas exchange takes place at the capillaries. That's the teeny tiny little web structures that we got. They're the smallest. The capillaries are 1 cell width wide. So that just kind of puts in perspective how small capillaries are. They're teeny tiny. And then goes back to the lungs, back to the heart, back to the lungs, where that gas exchange happens again. They get loaded up with oxygen and then kicked back out the door. Here's that same picture. That should look familiar to you. So same kind of thing. There's your little ravioli. That CO2 goes out, it gets offloaded, we breathe it out, and then that oxygen goes in and gets loaded back up onto your red blood cells. And then this is kind of a visual example what happens at the cellular level distally. So once that blood gets where it needs to go to the tissue, it gets offloaded, the oxygen and nutrients get loaded onto our cells for metabolism to happen. And whatever is that byproduct of metabolism gets kicked back out the door, right? We're basically giant trash cans.
I got a silly question. So there's a lot of imagery in this book. Is it a good practice to say that things that are colored red have oxygen and the things that are colored blue have carbon dioxide?
For the most part.
Okay.
Yeah, if it's red, usually it's oxygen. Blue is deoxygen. Or if you're talking about like our stretchers, red makes it move. That's one of them. Yes.
Oh, I was just, because I was not reading this book, it said something about whenever we breathe in air, whatever air makes it down to the air sacs, the bottom, there's only air that gets converted, but the rest of it don't, because it don't make it down there, probably was called.
It's usually it's like our dead space. Yeah, our dead space. It's just air. It's just chilling.
That's where I got the 100.
Oh yeah. Dead space is, yeah, because I mean, you take a breath in, and then you let it out, but then you can still take more and go, like you could still push more out of your lungs. So it's just chilling in there, and usually whenever we're like pre-oxygenating, like Chaz was talking about, we're trying to get somebody so loaded up with oxygen, we're trying to oxygenate that dead space air, if that makes sense. We're trying to just get as much oxygen as in there as we can. That's a good question. Good job. Good job. All right, so blood vessels. So our vessels, like we were talking about, they can dilate or they can constrict, just like your pupils can, right? So this is also assisting our body with homeostasis. So whenever you go like work out where you get like really, really hot, you can see your veins really, really good, right? Because they dilate, they get bigger to allow more blood flow to our extremities. Whereas if you're really cold, it's hard to find somebody's veins, right? Your veins, like my hands right now are freezing and you can't see my little veins. But if I'm like too hot, my veins are going to pop out. Our vasculature changes. When it gets smaller, it's vasoconstriction. So vaso meaning blood vessel, right? And then constriction meaning, right, to constrict. And then what do you think it means, or what do you think the word is when it gets bigger?
Vasodilation.
Vasodilation. Good job. So our bodies, our little vessels are trying to help us out too. This becomes important to know because whenever we start talking about somebody in like a shock state, is in some kind of hypoperfuse state, their blood vessels are going to constrict peripherally, so away from the core, to try and push as much blood as it can to our vital organs. Because our bodies are trying to save themselves. Sometimes it helps, right? So that's what one of the systems in place, like whenever you start going into shock, your vessels are going to go right away from the heart to give the body more blood. And that can be kind of tough because if you're dealing with someone that's really, really sick, really, really like in shock, and you put a pulse ox on their finger and everything here down is all clamped down, you're not going to get a good pulse ox reading. So that's why we have like the little ones that go on your ear. I'm sure you've seen them on their foreheads. That's why they do that. Yeah, it's like a sticker you put around the forehead. Yeah, it's kind of crazy. I seen one the other day. You can take one of those OPAs, those airways that we were showing you, and you can wrap it on the OPA and put it in their mouth. If it's like a bad burn patient or like a really septic patient, and if they're intubated, obviously no gag reflex, you can put it in their mouth and it'll read it off of their tongue. So kind of cool. I've never tried it. I want to try it. All right, so blood vessel dysfunctions. So again, our body made up of our pump, right? Our heart. We have our lungs that kind of go along with that. We have our vessels, and then we have the blood that fills our vessels and things. So plasma, all that stuff. So if the pump's affected, it's going to affect everything else, right? If the lungs are affected, it's going to affect everything else. If the volume of blood in those vessels is affected, it's going to affect everything else. Well, then if those vessels get affected, that's going to affect everything else as well. Whenever we're talking about loss of tone, this is the loss of ability for those vessels to constrict, to maintain that homeostasis, right? So those blood vessels are like, oh yeah, we're squeezing, and then they're just like, never mind, and they just relax. Whenever you relax, obviously everything's going to pool. Your vital organs aren't going to get the blood that they need. So when we talk about loss of tone, those vessels are like, they get floppy. So blood pressure drops, obviously, because our pressure is the pressure inside of our vasculature. What are some things that might cause a loss of tone in your vasculature? 7. Is it really already 7? Yeah. Oh, wait. What are some things that can cause loss of tone? Huh? Trauma, yeah. So any kind of spinal cord injury can cause a loss of tone. Anaphylaxis is a big one. So anaphylaxis, that can cause your blood vessels to just say, hey. So there's your normal vessel, fluid's all the way to the top, and then you have loss of tone, you get this big space, it's not able to push that blood where it needs to go. So allergic reaction is a big one, infection, trauma.
What is that space filled up with when it dilates like that? Because if it's normally filled with plasma, what would that be filling with?
Probably nothing.
So if it's negative pressure, then would it, but that doesn't really make sense.
I'm not 100% sure, actually. It might like collapse in on itself. I mean, because if this is like completely dilated and it's all a negative pressure system, it might just collapse in on itself.
Okay.
That would be my assumption. That's a good question. All right, so permeability. Remember, this is where that outside of the cell is able to allow fluid in and out like it's supposed to. Whenever it's letting too much fluid out or too much fluid in, those walls get leaky. That is called excessive permeability. So I think there's a picture. Yeah. So the vessels get real leaky, not only around the cell, but even like the vasculature. It can leak out. That's where that edema comes from. So severe infections, sepsis is the big one that can cause your leaky vessels. So we're always on the lookout for sepsis. You're going to learn the criteria for sepsis. It's going to get drilled in your brain because it's a huge killer of many patients. High altitude can also cause excessive permeability and then certain diseases.
Can you go back, please?
I thought there was going to be another picture.
What's edema again?
It is a buildup of fluid.
With the high altitude, whenever it does that, you talk about the variability, would that be because it's trying to allow more oxygen to be able to come in, like any of it at all, just makes it
Yeah.
sound better?
Yeah, like your body, because it's that negative pressure system. Same kind of thing of like whenever you're diving, that air that is in your vasculature can actually escape and cause us air bubbles. And so cause like problems like in the joints. So there's like too much pressure. And the fix for it is usually steroids and getting them to a lower elevation. So, all right. So systemic vascular resistance. Systemic meaning your whole body system, systemic, right? So the pressure inside of our vessels is our systemic vascular resistance. So if you have a high systemic vascular resistance, that usually is like your hypertension. So your vessels everywhere else is like so clamped down, your heart's trying to push against it, it's going to cause high blood pressure. There's a lot of pressure in those vessels. So obviously we all know, we've all seen the AHA signs in the doctor's office. They're like, high blood pressure can cause strokes and heart diseases, right? Every box of Cheerios also has this. So if your body lives in a hypertensive state, what does hypertension mean? Hyper meaning high, right? It's high blood pressure. It's a fancy name for high blood pressure. So hypertension, tension.
So if I eat Cheerios, it's helping out.
That's what they say. Honestly, I don't know if I believe it, but somebody paid off the freaking AHA and it was Cheerios.
The little big guy is a criminal.
He is. He is. They're like, eat our sugar cereal. So if somebody lives in a high blood pressure state for a long time, what's part of your heart, do you think? Because our heart's a muscle, so the more you work it out, the bigger it's going to get, right? So there's a very specific disorder that hypertension causes. Does anybody think of what ventricle it affects? So one of the ventricles down here, it is the left ventricle. Why? Because the left ventricle is what pushes it out to the rest of your body. So if you have high pressures in your body all the time and your left ventricle is pumping really hard to get that blood out there, it's going to push you.
So is that like permanent enlargement of the heart?
Yes.
I don't know what
Your left ventricle's always in there.
So if you lived in that state of hypertension for a long time, but then you like came out of it, would you just permanently?
I feel like you could probably, like, it eventually would start to go down a little bit, but it would take a long time. Yeah, I mean, it's left ventricular hypertrophy is what it's called, but it's just a buildup of that muscle. But then once you affect, like, the heart, like, your electrical change as well, so it would all have to go back somehow. I'm sure it can. It'll probably just take a little bit. I'm not sure. All right, so loss of regulation. Chemical messengers tell blood vessels when to dilate and constrict. They're like, hey, my body needs more of this, less of this. And then if those signals are blocked, those problems arise. So lack of sympathetic response can cause shock, right? So what is sympathetic response? Fight or flight. Yeah, it's compensating, right? So what kind of vitals are you gonna see? Heart rate, higher blood pressure, right? As soon as you lose those things, shock. Different types of shock. Good, good, good. All right, so the heart. Each output, so each lumped up 70 mils of blood. That's what fills up and gets pumped out on average, 70 mils of blood per contraction. So whenever we talk about the heart, whenever we're talking about how much blood goes into the heart and how much is pressed out of the heart, it's called stroke volume. So the amount of blood coming into the heart as it relaxes or into like your right atria, right ventricle is going to be called your preload. So this side of your heart affects your preload. Your contractility is how hard the heart squeezes. So how hard is it squeezing, right? Different things can affect all of that. And then you have your afterload. So this is where that left ventricle needs to press against to get it out to the rest of your body. That's your afterload, right? So preload is how much blood is coming in. Afterload is how much blood is coming out. And then your contractility is how hard it's squeezing with each beat.
Go back to Spruce things.
I know it's already like 7 something. Yeah. Yeah, I was gonna say, if anybody needs to go to the bathroom, just go ahead and like step out. Because I'm gonna try and get through this and not keep y'all so late. This is kind of a long one. A&P and pathophysiology. And then the OB chapter, that one's also.
So funny, my brother, like he's only been working for 35 months, like a month.
Mhm.
He's like, I've never been deliver a baby. This first call, I would have thought it was childbirth.
Gross.
I was like, dude. He goes, how did you luck out when I happened? I'm just that good.
Listen, there's something you learn in your clinicals. If it's wet, sticky, and not yours, you don't touch it. And then if you're dealing with childbirth, that's a lot of wet, sticky, and not yours, but you have to touch it. And
Yeah.
it's disgusting. And Miracle Life is great. I just don't want to be there for it. So, all right, stroke volume times the beats per minute. So remember, stroke volume is preload, afterload, right? And that's about 70, right? So stroke volume 70 times beats per minute is our cardiac output. So if your heart's not able to fill up with the correct amount of blood because it's beating so fast, it's almost like taking a big old swimming pool and a bucket and you're filling the bucket up and dumping it into the swimming pool, right? If you go really fast, it's going to take you a lot more loads to get that swimming pool full because you're not letting as much fluid get into your bucket, right? So if your heart's beating way too fast, it's not going to fill up as it should. Whereas if it's beating too slow, it's not going to get the perfusion out to the vessels as it should in like a normal heart rate. So any one of these two factors, so a slowing heart rate or decreasing stroke volume, can reduce cardiac output. So if you talk about something like a myocardial infarction, which is just a fancy word for what?
Heart attack.
Heart attack, good. So a heart attack can affect certain parts of your heart that like don't allow it to fill up all the way, or it makes it go too slow. So any kind of pump problem is also going to cause shock, right? So again, that fast heart rate doesn't allow you to fill up your bucket, and it's not going to be able to fill up the rest of your body to get the oxygenation that it needs. Is your hand cramping yet? Yeah. All right, so here's just a picture. Your oxygenation, the little guy. You go and look at this one. Did you already take a picture of this one? Okay, got it. So here's just another picture. Your afterload is what's going out into your body. Your preload is what's coming into your heart. How much blood there is your cardiac output, and then obviously your oxygenation on your lungs. So kids, whenever we talk about adults, their compensation is like a blood pressure. As soon as you know that they are no longer compensating, their blood pressure goes down. So they're in a shock, their blood pressure goes down, they're no longer compensating. Kids are different, right? So kids, they rely more on their heart rate to compensate than adults do. So whenever you have a kid and you're suspicious of any kind of shock, don't wait for their blood pressure to drop. If you wait till their blood pressure drops, they might as well be dead. It's too late. You're too late on fixing the problem if their blood pressure drops.
So will you typically see?
Tachycardia, hypoxia. And then their heart rate starts to go down. Once they're hypoxic, they get bradycardic. And then their blood pressure drops. So there we go.
What would cause like a child's heart to feel so slow?
I don't know if that's
It's
just physically
like it
explode.
just, yeah, it physically just went, like it beat too fast, too hard, and then it just,
I don't know if you could like physically explode.
I don't, that's just the way it was phrased.
I mean, there's lots of things. Hypertrophic cardiomyopathy, ST, emotional disorder,
Too much fatigue?
SVT.
SVT.
What does SVT do, like, if you've had it for real long?
It would dump your blood
Yeah,
pressure, usually send you
for
to shock.
sure.
It depends on
So, yeah.
like the doctor though, because I've had patients that are in SVT and I take them to the ER and they just let them chill in SVT until they show signs of like hypoperfusion. So sometimes people can compensate and they'll be fine, but usually you want to get them out of that heart rhythm. That's by shocking them or meds or vapors. Your body just can't compensate with a high heart rate like that for a long time.
So if you live like that and you didn't take the meds, you eventually die.
I mean, your heart,
Dies
like,
eventually.
every day.
Well,
The heart is a muscle,
that.
train until failure. I mean, eventually, I could see it like affecting, like your pacemaker node in your heart, like long term. If you're like chilling at a heart rate of 200, 24/7, like your body's not getting the blood that it needs. So eventually, everything will just start to fail, like organ failure, would be my assumption. Are you asking for a friend?
I actually do have a friend that has SVT.
Yeah. Just chills in it all the time?
Yeah.
Yeah, it's not good. Usually, I mean, once your body starts, your main organs stop getting the blood that they need, they'll start to shut down. But all of that's dependent on like your blood pressure. Because some people can live at a heart rate like kind of fast for a long time, whereas some people can't live in that heart rate as long. Does that make sense? You're looking for a map. Is what you're looking for. All right, so heart dysfunction, different things can cause our heart to go completely. All right, so physical trauma, if you hit the steering wheel, someone punches you in the chest, get shot, obviously that's physical trauma. Squeezing forces, so we talk about like that pneumothorax starts to squeeze onto the heart. The force of the actual heart beating, if that's too low, that's going to cause problems. And then cell death. So you might see a question that's like, what's the difference between ischemia and infarct? Infarct is the death of the cells. That's irreversible. They're dead. If it's ischemic, that means that it's not getting the oxygen that it needs, and death is the next step. But that is reversible. So ischemia is reversible. Infarct, not reversible. That is cellular death. So
You said ischemia is lack of oxygen.
ischemia is lack of perfusion to tissues, and that includes oxygen. So whenever we're talking about like a myocardial infarction, usually just one part of the heart's affected, right? So it can affect other parts of the heart. This is called a cardiac tamponade. So that's usually caused by trauma, but you have a sac that sits around your heart, and if it gets punched or hit or whatever, it'll start to fill with blood. and it'll put pressure onto your heart. So that's what that is. That's the sac full of blood. And then you have your pneumothorax, which we talked about, that crushes your heart as well. So not only is it affecting your ventilation, but it's affecting your mental heart. Okay, I'm trying to get through it. Did they have a question? Oh, sorry. I'll stand on this side. All right, so then we have electrical problems that can affect the heart as well. You're welcome. So you have electrical problems that can cause like damage to the heart. So if like one of your little pacemaker nodes goes out, that can cause problems. Low heart rate, obviously you're not getting the blood that you need to the rest of your body. Unorganized rhythms, what are the two that can be shocked?
VTAC?
VTAC. VTIP, fib, VTAC. Those are the ones that can be shocked. And then rate problems. So if your rate's too fast or too slow, that could be a big problem, obviously. There's a lot that goes into that. So everything must work together to maintain life. We have ventilation and we have perfusion. There's three main components, right? We have the pump, which is our heart. We have our vessels, and then we have the fluid that fills our vessels, right? The heart and the lungs kind of work together. But a disruption of any of those three main things, so the pump, the vessels, or the fluid, will send somebody into shock, right? So depending on what kind of shock, that's a whole other thing. So ventilation is our V, perfusion is our Q. Make that make sense. I don't get it. But the Q is the perfusion. So I like to draw the Q with the little arrows around it because it's being perfused around. So basically, again, you'll hear me say it 100 times. Air goes in and out, blood goes round and round. Any deviation of that is a problem. Oh, we're looking at what time? What time is it? A long one. Sorry. All right. So our types of shock, we have hypovolemic. So that's the fluid that fills our vessels. So low blood volume, that can be caused from dehydration. That can be caused from like physically bleeding out. Those are things that can affect that. We have cardiogenic shock, which is a pump problem. That is, something is going on with the heart, right? So then we have an obstructive shock, or a distributive shock. Sorry, that's the next one. So distributive is our vasodilation. That's where our vessels lose tone and they just relax. That causes a distributive shock. Does anybody remember what can cause that? Anaphylaxis, sepsis, right? So if you hear anaphylactic shock, that is a type of distributive shock. If you hear septic shock, that is a type of distributive shock, okay? Then we have an obstructive shock. So something is physically blocking the mechanics of your heart. So usually that's like your pneumothorax where it's being pushed on. That's an obstructive kind of shock, okay? Does that make sense?
So like the blood clot?
A blood clot in the lungs, that would be an obstructive shock as well. Yeah, so it's not allowing that blood to get pushed out. So the heart's working too hard to push against. That's obstructing the blood flow. That causes shock.
So what's a type of cardiogenic shock?
Like a myocardial infarction.
Oh.
Yeah. So cardiogenic shock, that can be from like a heart attack. That can be from some kind of like, yeah, like a dysrhythmia can cause a cardiogenic shock. So your heart's not pumping as it should.
But a stroke is obstructive.
A stroke wouldn't quite be, that'd be like more of a neurogenic shock. So that's affecting your brain. And that would probably, I mean, it depends because not everybody that has a stroke goes into shock.
Right.
If that makes sense.
If it did
Most
happen,
people don't.
shock from a stroke.
Yeah, that would probably be more of like a, what do you think, distributive?
If they weren't a shock from a stroke, it would be a hemorrhagic stroke and you die from hypovolemic shock.
Yeah, hypovolemic. Yeah, but it affects your like vessels. Like if you have a brain injury too, or like a spine injury, your vessels also dilate. So it's not really like a stroke is not a type of shock. All right, so perfusion, blood goes round and round, perfusion. Hypoperfusion is known as what? Not enough. It is shock, right? So regular delivery of oxygen and nutrients. So that is perfusion. That is homeostasis, right? Hypoperfusion, shock. And then obviously shock can lead to death. So as you're assessing your patients, we're always looking for some kind of shock, usually. That's what it all comes down to. So hypovolemic, that's a low blood volume. That's a how much fluid in our system problem. We have distributive, so that tone, the blood vessels, they relax. That's a distributive shock. Cardiogenic, the heart is failing to pump one way or another. Then you have your obstructive, so that blood cannot flow for whatever reason. So remember that whenever you see this on like a test, these are umbrella terms for other types of shock, right? So like distributive, like I said, sepsis, anaphylaxis, right? Hypovolemic, if you hear hemorrhagic shock, that's a hypovolemic shock, right? Does that make sense to everybody? That's kind of hard to get like a good grasp of, I feel. Yeah, umbrella terms, blah, blah, blah. All right, there's the classifications if you want to take a picture of this. So these are just different things that can cause these types of shocks. So if you hear like a distributive shock, like neurogenic is a distributive shock. Y'all are troopers. You're doing great. I know it's a lot of information all at once.
You said neurogenic is distributive?
It can be, yeah. So you have like neurogenic, but I feel like neurogenic can kind of be spliced into two types because you have like a spinal shock or you have a spinal cord injury. That's one thing. Then you have like somebody that's like bleeding out into their head that causes a different subset of symptoms.
That would be a hypovolemic.
That would be more of a distributive as well. Because if the spinal cord is not talking to your vessels, they're going to say, see ya. They're going to relax. All right. So whenever we're looking at a patient that's in shock, we want them to be compensating, right? What one vital sign for an adult tells you that they're no longer compensating? Blood pressure. Good. And for kids? Heart rate. Good job. So signs of compensation, slight mental status changes. So if they're slightly altered, they're a little bit confused, that can be, they're still compensating, but it's just not great, right? So increased heart rate. Their heart is trying to make up for whatever's going on in the rest of their body. So it's going to speed up. It's going to go into their sympathetic, right? Increased respiratory rate, also sympathetic, right? If you're sick and your body is starting to die, your sympathetic nervous system's like, let me take over and heal this person. And then sometimes it works, sometimes it don't. Delayed capillary refill time. What is that? Yeah. So you squeeze and then check to see when that white goes away. What's a normal cap refill time?
2 seconds.
2 seconds. Good job. Less than 2 seconds. I will say for an adult, not super accurate. You can try it. That's great. But like even me right now, mine's greater than 2 seconds just because my hands are cold. But kids, that's what your go-to is going to be is cap refill. Pale, cool, clammy skin. So you'll see some patients, it's snowing. You'll see some patients, they're just freaking gray. Yeah, I'll be safe. And then sweating, so that kind of goes into the clammy skin. Listen, this should be studied, and I've heard something about it, and now that I've had sick patients, I've noticed it. They should study freaking under eye sweat right here. The sickest patients I've had that are sweaty, their under eyes are sweaty. But if I have somebody that's just like working out, their under eyes are never that sweaty. They're glossy, but they're not like physical droplets. So it's always right here. It's very odd. That's not in any textbook, but it's just something I've noticed. I heard someone say it and I was like, huh. And then I started noticing it and I was like, okay. Yeah. Like physical droplets coming out from underneath the eyes. Thing. All right, so decompensated shock, right? So they're no longer able to help perfuse themselves. Altered mental status. When we say altered mental status, that could be a whole slew of things, right? So they say slight altered mental status changes for slight mental status changes. But altered mental status, if they're completely out of it, they're trying to eat the pulse ox off of their finger, that's altered mental status, right? They're not able to respond to you at all. That's altered mental status. That's why I don't love using altered mental status, because it's such a broad statement. And then we decrease blood pressure. That's the big thing that we're looking for. If they go into irreversible shock, that is where those organ systems begin to die. And so that's usually irreversible. They're dead shortly after. So here's my little soapbox. It's only a few words today. Is your patients don't suddenly decline. You just suddenly notice. There is always some kind of sign or symptom beforehand, before they crump, that you should be on the lookout for. So that is up to you to know the signs and symptoms. All right. So our fluid balance, we are 60% water. That's a lot of water. So in the cells is 70%. In the vasculature, so our veins, arteries, all of that is 5%. And then our interstitial space, so that's kind of like in between all of that. And that's not very much. So 25%, 60%. This should be in your book as well. I'm sorry, I misspoke. Intravascular. So I said intervascular. All right. This should be in your book. So if you just want to look there. Sorry, I'm trying to get through this for y'all so you don't hear forever. All right, so brain and kidneys regulate thirst and elimination, right? Our brains try to control everything because they're silly. And then our kidneys is how we get rid of a lot of our excess of stuff, right? So our kidneys are like, hey, let me pee this out. That's great. Our brain's like, yeah, pee it out. So plasma proteins pull fluid into the bloodstream, right? So it's kind of trying to remain in homeostasis. And then that cell membrane and the permeability regulate the flow in and out. So what's one big thing that's going to affect permeability? What kind of shock? Distributive, good. And what sickness, illness? Sepsis, and anaphylaxis. Yep. Good.
So distributive shock is, what was the question?
What's the big one that affects capillary permeability?
Thank you.
Those are the ones you're going to see on tests. Sepsis and anaphylaxis. All right, so how many of you have seen this before? Edema, yes. I will say, this is my little tidbit to y'all. Even if somebody has chicken legs, push on their legs still, because I have had many patients that their legs don't look swollen at all. They look normal, and I go to push on them, and there'll still be an indent. So this is called pitting edema. So whenever you push in and you release, and your little fingerprint stays there, that is pitting edema. You see this a lot in like kidney failure patients. You see this a lot in like heart failure patients. They get that buildup of fluid. And so if you have someone that's like really difficulty breathing, you can't really hear lung sounds, can't really tell, and then you go and look at their legs and you're like, okay, do you have congestive heart failure? And like, oh yeah, but I haven't been taking my meds for 3 years. This is usually what you'll see. You already know what edema is. And this can happen in any kind of low points, right? So depending on what side of the heart is being affected, we'll get more into this in like cardiac problems. But that fluid's either going to build up in their body or in their lungs. And so it's always going to settle to the low points. So usually it's the legs. That's the most common way or place for it to go. But know that if they sit like on a recliner a lot, it can build up right here. It's called sacral edema. And sometimes they'll have like this big pooch like right above their little butt crack. And you go to push in on it and it does the same thing. So just know that that fluid can build up elsewhere besides the legs, in the hands, what have you. Usually it starts from the lowest point and works its way. So spinal cord, brain, they are well protected by bone and muscle. They have to be, right? Because as Calvin likes to teach, he taught me this, is that if you drop a dime on your spinal cord, it will sever it. So not good, not good. Very sensitive. Huh? Yes, the spinal cord. So the meninges cover all of that. And then there's a layer of shock absorbing fluid called cerebrospinal fluid. You'll hear it called CSF. So if you ever see CSF on the outside, that is a bad day, right? So there's something going on where there's like a crack in the skull. If you see CSF coming out the nose or the ears, it's a bad day. This is for everybody. And so it's still subject to damage from trauma or disease. What is the inflammation of the meninges called? Meningitis. Yeah, so that's a big one that we like to look out for, right? So if someone has a lot of neck pain, if you've ever seen an autopsy photo, I think I have one in one of these slides of meningitis, their brain like looks green. It's kind of gross. So here's just this might be in your book as well. So it's all protected. It's all in enclosed space. So if there's ever there's a perfect balance of CSF, brain, and blood in our brain. If there's any disruption between those three things, bad things start happening in our head, right? So we have these little protective layers. There's one called the dura mater, which means tough mother in Latin, so that's cool. Then you have your arachnoid mater, and then your pia or pia. So you can get like head bleeds in between any of these three layers, and then you can also get them inside of your brain. So there's different kinds of head bleeds depending on where they're going to be, but just know that like any kind of trauma or anything inside the brain, that brain's got to go somewhere once it starts to swell, and it's out of what hole?
Foramen magnum.
The foramen magnum.
Magnum.
Foramen magnum.
All right, so nervous system. So any kind of trauma is a big nervous system dysfunction problem, right? So motor vehicle crashes, falls, diving accidents. The test question that you see on the NREMT is always, somebody dove into a pool and now they're shallowly breathing. They have a spinal cord injury. That's always the answer. You're going to see it somewhere or another, whether it's not on NREMT, you might see it just scrolling. It's always they dove into the shallow end of the pool, and it's a spinal cord problem. So you can have a medical dysfunction problem. So obviously our strokes can affect all of our brain stuff. Meningitis, there's that word. Lou Gehrig's disease, MS, and then hypoglycemia is a big one, right? Because our brain needs glucose to function. So if you have low glycemia, so hypoglycemia, that can cause a lot of problems. Any kind of neurological dysfunction, you should always check a blood sugar. So low blood sugar can present in a lot of different ways. And never call a stroke alert without checking a blood sugar. We'll learn about that more later, but everyone's done it, so it's fine. What's that? Good. What other, this is kind of later in chapter, what other signs and symptoms do we use to check for a stroke? Arms, and what else? Speech. Yep. So facial droop, arms, speech, and time. Yeah, fast. Good job.
What about pupils?
So pupils can cause, but just know that like some people have like chronically unequal pupils. So I wouldn't be like their pupils are equal, they're having a stroke. I'd be like, here's all the other signs and symptoms of a stroke. I'm going to call a stroke alert. Let's look at their pupils. I wouldn't call a stroke alert based on just pupils.
And disorientation?
Disorientation can be a sign of a stroke, but I also wouldn't be like, they're disoriented, it's a stroke. There would have to be other things going into that. All right, so our endocrine system, we learned about this. Our glands secrete hormones. So we have the picture that we went over last class. So our hormones send chemical messages to our body to control our body functions. This is that, what's the word I'm looking for? The bulging of the eye, the exophthalmos that we were talking about, where their eyes like start to bulge out. So not enough hormones, type 1 diabetes, that's a big one that usually goes there. Too many hormones, like Graves' disease. If you have like an Addisonian crisis, that can be like too many hormones. There's that tumor that likes to sit on top of your adrenal glands, your pheochromocytoma, that can cause these problems. So usually, for the most part, people that have endocrine system problems, it's rare for us to just, I will say that these are like the patients that will present and you're going to be like, what the heck is going on with them? Unless it's a diabetic thing. But if it's like a too many hormones thing, you're going to be like, what the heck is this? And then later you're going to find out it's like Graves' disease or Addison's or adrenal hyperplasia or some weird shit. These are very hard to identify, like just by looking at somebody. This is that adrenal insufficiency we were talking about. So if somebody has adrenal insufficiency, they know it usually, hopefully. They carry around this little steroid bottle with them. It's called Solu-Cortef, and most states have like their own protocols for paramedics to give this. If they don't have it on them, then they need to get steroids fast. So that's one of those things. If they know they have an adrenal insufficiency, and they're in like an adrenal crisis, their heart rate's real high, they're hot, they're like confused, and you don't have this available, you need to get them somewhere with steroids quick. They made a big deal about this because somebody important's kid died because of it. They needed, and the paramedic didn't know how to deal with it. And so now they're like, tell everybody about this because somebody important died. So
Increased heart rate, confusion, you said?
yeah, like if they're like hyperpyrexic, so if they have like a high temperature, they're breathing fast, they're altered, high heart rate, high blood pressure, like all of that. All right, digestive system. So this is how we get our food, water, and nutrients. Stomach and intestines. So fun fact, you have another little sphincter that sits right there on top of the stomach. So that's cool. Sphincters. So if you have a dysfunction, this can affect your hydration levels because that's how we absorb our water, right? Is through our digestive system. If somebody has like diarrhea for many days, someone has vomiting for many days, that usually causes some kind of dehydration. So that's a big thing. And then you'll see here like this coffee ground looking thing. That's vomit. That's coffee ground emesis. So that, if you ever see that, it's some kind of GI bleed. There's a bleed going on somewhere in there. That is partially digested blood. That's what that looks like. It looks like someone swallowed a can of chew and then threw it up. That's the best way I can describe it. Melena or melena, however you say this, it looks like grape jelly. If they're pooping blood, that's also another sign of a GI bleed, grape jelly poop. Now, if you have somebody with like bright red blood coming out of their butt, can be like a lower GI bleed for the most part. Most of the time, it's going to be like hemorrhoids. So if you ever get a call for someone pooping blood, it's important to ask them, what color is it? Or show me. I know it sucks, but it's important to know these things. If it is digested blood, though, you are going to smell it. That is one of the stankiest things I've ever put up my nose. So it smells like someone took freaking chicken, tossed it in like a hot, like metal trash can in the middle of summer and let it stew for like 3 days. That's the best way I can do it. You can smell it as soon as you walk in the door. Disgusting. All right, so our immune system, this is what fights our infection. So it responds to specific body invaders. It marks them. And then next time that invader comes, it's like, and that's where anaphylaxis happens, basically. But our immune system also deals with like viruses, certain kinds of bacteria, all that stuff.
Isn't that from a type of white blood cell?
A leukocyte?
Yeah.
Like,
that like remembers past.
So our white blood cell deals with like our immune system. That's like any kind of infection, and you have like an increased white blood cell count. That's where all that comes from.
There's something that remembers past, like if you get the chicken pox, so you don't get it again.
Oh, like an antibody, or what's that?
But what produces the antibodies? That's or like calls them. Starts with an L, right?
Leukocytes. I don't know. I'm not sure. Do you know? Lymphocytes. Thank you, LV. This buddy, he's so smart. He's our doctor, our surgeon. This is our last slide. So hypersensitivity, also known as an allergic reaction. So if you ever see the word hypersensitivity, they had an allergic reaction. Now, an extreme allergic reaction is called anaphylaxis. So you can have an allergic reaction and not be in shock. But if you are in shock because of an allergic reaction, it is called anaphylaxis. So, and there are rules in identifying like, yep, this is an anaphylaxis or this is just an allergic reaction. And we'll learn about those later. Our immune system's basically like, freaks out. So this is where our vessels, they lose tone, they get very permeable, they get fluid, that leaky fluid. Leaky fluid is in the space that it shouldn't be. It looks like she has 2 mouths for eyes. This is our last slide. So the only thing you missed, hypersensitivity is an allergic reaction. Not every allergic reaction causes shock, but if it is causing shock, it is anaphylaxis.
Does anaphylaxis always have to do with breathing?
Not always. So the rule for anaphylaxis is if it involves 2 or more body systems or breathing. Like, so if it's just affecting the lungs, it's still anaphylaxis. But say that I ate some peanuts and I'm allergic to peanuts, then I'm puking and my blood pressure is low, that's anaphylaxis. So any 2 or more body systems or breathing gets just 1. So you ever hear wheezing? Also, I was also taught lips are not part of your airway. So their lips can be big, swollen, huge, but you don't hear any stridor, that noise that we were talking about, or like wheezing. It's not considered anaphylaxis unless there's another body system involved. Whereas like you think of hives, that's 1 body system, right? So if I had hives and puking, that is anaphylaxis. Does that make sense? It's a lot. We'll talk more about it later too, though. So, what questions do y'all have? I know that was a lot. I think, what time is it? Only 15 minutes, so not bad.
Sodium potassium pump, you mentioned at the very beginning before, is that part of the cell membrane?
Yeah, so it helps like the influx of sodium and potassium get in and out of our cells so they can function appropriately.
And then in the sympathetic nervous system, we talk a lot about fight or flight, but what about fawn? You know, like when it freeze.
Oh yeah, fight, flight, or freeze.
Yeah.
It's just another reaction. So
But it is
your
still
heart
part of
rate's
the
still going to go up. Your
system,
breathing's
so
still going to go
for
up.
sympathetic.
Some people just shoot themselves.
That sounds like a rough day.
It's an insurance payout though.
What?
It's an insurance payout.
If you shit yourself?
I'm sure it is. Because if you shit yourself, poop yourself after an accident, to me, as a medical provider, oh yes, I have to show these. I'm going to assume you have a spinal cord injury. Okay, I'm gonna write it on. I'm gonna write it on this board. They need to see this. I'm sorry to keep you all late. I promise this don't happen every class. It's just these big chapters.
Thank you. Who did you send those? Lovely. Thank you very much. That types of shot is gonna throw me for a loop.
You just gotta stand up.
Okay.
I have more questions. Oh, but you guys should really watch that. Well then, have you seen Cells at Work? Still doesn't work.
Oh, really?
10 out of 10.
Looks like it.
Not a set.
Yeah, it's
You
still
would like
snowing.
it.
Don't worry, it's still snowing.
You watch anime, yeah?
Yeah.
Oh, no, you don't have to.
So does it work.
Make sure that they can see that.
Sure.
Can y'all see that okay?
I wasn't.
But if you say,
I punched you.
So. Oh, like, yeah, this started snowing fast. What was that, Steve, about 1 o'clock? What? When it started snowing last night? It was like 1 to 3.
Yeah, I gotta ride with you, cause,
I
Jessica's
think it was
like,
like 1 o'clock.
I don't know, I was sleeping, so we're good.
did y'all get
Yeah,
that?
that's why there was a bunch of dust come up.
Yeah, you guys are good to go. Thank you. Sorry for frying your brains. It won't be the last time. Okay, okay. Now, we'll go in. We'll go to the hour. Not a problem. Marissa. Yeah, yeah, yeah. No, you're hurt. Can I steal your heart? This one?